Assalamualaikum warahmatullahi wabarakatuh. Greetings to everyone. It's a pleasure to meet everyone here, although only virtually and asynchronously. I hope that everyone is in good health. In this lecture, I will discuss about the role of radiotherapy in cancer treatment. Radiotherapy is a treatment modality using ionizing rays or high-speed particles. Ionizing rays is a part of the electromagnetic spectrum wave with a certain wavelength. When this energy passes through a biological matter, it will produce an ionizing effect which can result in cell death. Here is the outline of this lecture. We know that almost 100% of radiotherapy is given to treat malignancy or cancer. That's why I think it's important to start with discussing the burden of cancer in the world and also in Indonesia. Cancer is known as the world's most deadly disease, where we expect to see a significant increase in cancer incidence with an estimation to reach 30 million cases in the year of 2040. The highest incidence is for lung cancer, prostate and colorectal cancer in male, and breast cancer, colorectal and lung cancer in females. It is also stated that in every 1.1 second there is a new person diagnosed with cancer, and that in every 2 seconds there's death due to cancer somewhere in the world. Sadly, 70% of these occurs in lower middle income countries, including Indonesia. Now, looking into more details on cancer incidence number, let's look, for example, for the numbers in Asia. If we divide the countries into categories based on their GNP per capita, which are lower middle income countries or the LMIC, the upper middle, and last is the high income countries at the far right, and we see the cancer incidence number in those countries and then calculate the average, we will see that the cancer incidence in the higher income countries here are 6 to 7 times higher than in the lower middle income countries, which brings us to question, how is this true? So the question is it true that there are more cancer cases in higher income countries? Now, if we look more closely and compare between cancer incidence of higher income countries in Asia, in the colored table in the left, and other countries in the world in the right table, we can see that the number is actually quite similar. It is between 4 to 7 cases per 1,000 population. So it means that cancer cases in lower and upper middle income countries are underreported. Why? This is thought to be because in higher income countries there are better cancer awareness and knowledge in the public and also in medical personnels. There are better access to medical services, and there are increased life expectancy, and also there are better reporting cancer registries. How is it in Indonesia? There is a significant increase also, where in the year 1990 cancer is in the 8th rank of highest incidence, and in the year 2017 cancer became the 2nd highest ranked disease. There is also another data which shows that in the year 2012 cancer is ranked at number 4. Cancer incidence in Indonesia based on the GloboCan, which is the Global Cancer Data Center, is 1.3 per 1,000 population with a mortality rate of 0.7 per 1,000. The highest incidence in female are breast cancer, cervical cancer, and ovarian cancer, while in male is the lung cancer, colorectal cancer, and liver cancer. In total, the highest incidence are for breast cancer, cervical cancer, lung, colorectal, and liver cancer. In Indonesia, the cancer incidence in female is 1.5 times more than in male. This is because the highest cases of cancer here are breast and cervical cancer, which are specific in women. These graphs show that it is estimated that there will be up to 70% increase in cancer incidence in the year 2040, and also a 78% increase in mortality rate due to cancer. Our National Health Insurance (BPJS) data showed that the government spending for cancer treatment is the second highest, or 17% of total, only after cardiac diseases. This is among the spending for catastrophic diseases, which accounts for 20% of all total BPJS spending. Now, what is cancer actually? Cancer happens when cells somewhere in our body begin to grow out of control. The cell became immortal due to many factors, including carcinogenic agents such as chemical compounds, viruses, radiation, or an underlying genetic abnormality. These factors may affect several cellular behaviors, especially its ability to proliferate and also apoptosis or programmed cell death function. These changes result in the immortality of the cells, and thus it develops into cancer. What is the cause of cancer? Unfortunately, this is still unknown, but we can already identify many risk factors, which are things that will increase the chance of someone getting cancer. These factors can be divided into two: things that we can control or modify, such as smoking, alcohol, diet, physical activities, and chronic infections, and things that we cannot modify, such as our age, ethnic, family history, and personal health condition. If we can avoid the modifiable risk factors, we can actually reduce the chance of getting cancer around 30 to 50%. This is known as primary prevention. The WHO recommended only 3 important things, which are no tobacco, healthy diet, and prevent infection. And they state that it will reduce the probability of someone getting cancer up to 43%. Now, let's discuss briefly on cancer treatment in general. A cancer treatment principle is not the journey of survival of the fittest. It must be an evidence-based treatment with the ultimate goal not only calculating tumor control of the patient's survival, but it must also take into account a good quality of life for patients throughout the journey. Now, here I would like to mention briefly how treatment modality in forms of drugs or other modalities can be utilized in the clinics. It has to undergo many robust phases, and not any one of these can be skipped. For example, a drug has to start at preclinical phases, and then it can enter the clinical trial phases, phase 1, 2, 3, and so on. In medicine, there are 3 categories of treatment. The first category includes modalities which has enough data with proofs of medical evidence for its benefits and side effects. These are called evidence-based treatments. The second category is for treatments with scientific basis and rationale, but still has not enough data or evidence. So these are called novel treatments, usually for modalities still in research trials. And the third one are actually all other treatments out there with no logical rationale or scientific basics. And of course, it has no scientific evidence. Usually, these circulated only based on individual testimonies. All cancer treatment must start with a good staging process. Cancer staging is the information of tumor expansion, either locally or systemically to other organs in the body. This is typical of a cancer aggressive behavior which can result in mortality, which is its ability to spread distantly, or what we call as metastasis. The treatment strategy is decided after the staging process is finished. It has to be evidence-based treatments, and in most cases, it will be a multimodality treatment from multidisciplinary teams. Almost none of cancer cases can be cured by a single modality, except certain cases like some hematological cancer and several solid cancers which are found and treated very early, like cervical cancer and nasopharyngeal cancer. This is an example of an algorithm from our national guidelines for cervical cancer treatment. You can see that it consists of multidisciplines and that treatment strategy is heavily influenced by the cancer stage. Now let's continue to discuss about radiation oncology, or the treatment which is more commonly known as radiotherapy. The discipline of radiation oncology is a discipline of human medicine which concerns with the causes, prevention, diagnosis, and treatment of cancer, especially treatments using ionizing radiation. The treatment is commonly known as radiotherapy or radiation therapy, and the specialized physician is called radiation oncologist. In Bahasa Indonesia, we are called Spesialis Oncologi Radiasi. Radiotherapy is a clinical modality which utilizes ionizing irradiation to treat diseases, especially cancer. Radiation has no smell, no taste, and no color, and therefore, in every radiation facility, there must always be this yellow and black sign which is specific for radiation, and it has to be visualized clearly. We will come back to this and discuss more later. Now, there are many types of ionizing rays that can be used for radiotherapy. In general, it can be divided into electromagnetic waves and particles. The difference is that particles have mass. Examples of electromagnetic waves radiation are X-rays and gamma rays, while particles, for example, we can see in the figure here that the smallest is electron particle, next is pion, proton, neutron, carbon, and neon. These different types of ionizing radiation have different physical characteristics. For example, shown in this graph, which is the percentage depth dose curve of electron radiation, we can see that the higher the energy of the electron, the deeper it can penetrate, along with the higher surface dose. These differences will impact their clinical implementation, which may enable us to sculpt the shape of the radiation given, to make it confirmed as much as possible with the target or the tumor, as shown in the picture here. In general, there are two types of radiation sources, which are natural sources such as the cobalt, and from electricity, which are called linear accelerators or the LINACs. Briefly, radiation can be delivered in two methods. First is externally, where there is a distance between the radiation source and the target. And another method is brachytherapy, where the radiation source is placed closer to the target. Either it is inserted by needles interstitially or placed in a cavity. This method is used for cervical cancer, in example. What would happen when ionizing radiation passed through a biological matter? There will be various damages in forms of direct and indirect effects. Direct effects happen when ionization happens directly in the DNA, while indirect effects is when it happens on water molecules. As we know that 70% of our cells consist of water. These effects happen in normal cells and also in cancer cells. That is why therapeutic ratio is a crucial consideration in radiotherapy. The graph shown here is the therapeutic ratio, where the best scenario is that with the same radiation dose, we can damage as much tumor cells as possible with minimum effects to normal tissue. How does radiation kill cells, including cancer cells? We have talked about ionization effects which can happen directly in the DNA and in water molecules, where it will form free radicals. Here, sufficient amount of oxygen is needed inside the cell to stabilize the free radicals and lengthen the duration of its activity so that it could produce as many damage to the same target for cell killing, which is the DNA. The various types of DNA damages produced, whether it's single-strand breaks, double-strand breaks, or protein cross-links, all of them will induce an increase in protein p53, which will block the cell in the G1 cell cycle. In this situation, repair genes will be produced, and the damaged cells will try to repair themselves. If repair can be completed, then cell will continue to proliferate. However, if the damage cannot be repaired at all or only partially repaired, then the cell will most likely switch to the programmed cell death pathway or apoptosis. Radiation has no smell, no taste, and no color, and therefore safety issue is very important, which have been mentioned previously. Why it is important? Because the effects of radiation in tissues can be long life, starting with physics reaction, chemical, biological, and other reactions. So once again, therapeutic ratio became a very important thing to consider. This figure shows an example of a case in early use of radiation. A child with Wilms tumor was given radiation where it was also delivered to parts of the spine. The child survived the cancer and grows into an elderly adult, but unfortunately with severe scoliosis, because the irradiated part of the spine did not develop, while the unirradiated developed normally. Therefore, the vertebrae was curved, which we call scoliosis. We have mentioned before the importance of therapeutic ratio, so that our therapy should give maximum damage to tumors with minimum effects to normal tissue. Next, we will discuss about the role of radiation in cancer treatment. Radiation therapy has a role in broad spectrum of various types and stages of cancer, either as definitive therapy or as a single modality, especially for cases in early stages. For example, glottic or vocal cord cancer, nasopharyngeal cancer, prostate cancer, and also early cervical cancers. Or in combination with chemotherapy as sensitizers for more advanced cases, or as adjuvant treatment, which means a treatment modality given after the definitive treatment, usually after surgery. For example, in breast cancer, colon cancer, lymphoma, and others. And also, radiation can be given in palliative settings, in very late stage cancers to reduce the symptoms. And it can also be given for non-malignant cases, such as stereotactic radiosurgery for slow-growing tumor or vascular malformations in the brain. The little scheme below here shows that a neoadjuvant treatment is given before the definitive treatment and adjuvant treatment is given afterwards. This is an example of local radiation delivery to early stage vocal cord malignancy with the benefit of preserving the function of vocal cord. The colorful images shows the isodose distribution. One color represents a certain dose delivered to the target. The dose is gradually reduced towards the external part of the body. So you see that we can direct the focus of the radiation to the target area. This algorithm shows how multimodality treatments are given for cancer. This is another example for head and neck cancer. You can see that radiotherapy has a role in many parts here, as definitive treatment, adjuvant treatment, palliative, or even as salvage therapy. I am displaying here two papers which showed a value called RTU, radiation utilization rate. This value is calculated by a quite complicated formula from numerous data of various types of cancer, which finally show a result that the global RTU is around 50 to 53%. This means that among 100 cancer patients, 50 to 53 patients will need radiotherapy in their cancer journey. However, if we go back to the cancer incidence data of our country, Indonesia, here, if we try to calculate the RTU based on our data, we can see that the RTU in Indonesia is much higher. This is because, for example, breast cancer in Indonesia is much higher than the global data used in the previous papers, and also cervical cancers, lung and colorectal cancers. Several health economics publications have been summarized by the UICC, the International Cancer Control Organization, shown in this slide. They wrote that an increase in radiotherapy access will not only result in benefits in saving lives or therapeutic advantage, but it will also have the potential for economic returns. More details about this will be discussed in session 3 of this lecture. We have discussed before about therapeutic ratio. Therapeutic ratio, once again, is to find a balance between the effect of radiation to produce damage to the tumor with minimum effect to normal tissue. Now, how can we reach an ideal therapeutic ratio? Let's see here on our left-hand side is a curve showing a non-ideal therapeutic ratio, where you can see that the curve for tumor damage and normal tissue effect are very close to each other. On the far other side, on our right-hand side, it shows an ideal therapeutic ratio, where these two lines are apart from each other. Now, in between these two graphics, we can see the progress of radiotherapy, which actually is always in line with the progress of diagnostic radiology. When diagnostic radiology started to use 3D imaging, radiation oncology also progressed into that technology. We started to use 3D radiotherapy, whether it's conventional 3D or IMRT. And when they started the 4D technology, we also started using it. Now, the purpose of diagnostic radiology is to find where is the radiation target that we will need to kill, while the purpose of radiation oncology is to analyze and shape the radiation therapy given to be exactly what is found by diagnostic radiology. Besides that, our job as radiation oncologists is also to approach movements of targets due to movements of various organs at any given time in the body, and also how to manage findings from theranostic imaging. Theranostic imaging is a biological imaging modality which shows that inside a tumor mass, not all parts have similar characteristics. Some parts may have higher proliferation rate, or some other parts are more hypoxic than the others. Now, radiation oncologists have to be able to produce a clinical drawing or delineate a certain area to receive higher dose than others. Last is about radiation safety. We are dealing with something with no smell, no taste, and no color, remember. How can we guarantee that the radiation beam we planned according to the shape of the target can really be given to that area? How can we guarantee that the shape of the radiation beam, the delivery and placement of the radiation is really done according to the plan? We will discuss more on this in a later session, but briefly here I would like to mention that we use a system called multi-layered filtering to prevent incidents or near-miss events so accidents can be avoided. In the next sessions, we will also discuss advancement in knowledge and technology in the field of radiation oncology so that we could exactly sculpt the radiation beam according to the real target to increase the therapeutic ratio. This ends our first session of the lecture. Next, we will discuss about milestones of technology in radiation oncology, how technology advanced so that we can shape the radiation beam into the target that we want, so that we could achieve an ideal therapeutic ratio. See you then. Thank you.